Welcome to today's Explainer. I am absolutely thrilled to dive into this with you. We're tackling a massive clinical topic today, but we're going to break it down so it makes perfect logical sense. Our goal is to completely demystify the complex progression of colon cancer by using a highly visual pathology map. We aren't just going to sit here and memorize a list of symptoms. We're going to figure out exactly why they happen, from the very first cellular change all the way through to treatment and recovery.
Okay, let's dive into this. Here is our high-level roadmap to compartmentalize all this clinical information. We'll start with causes and symptoms, move into diagnosis, track how the cancer spreads, and finally look at surgery and chemotherapy.
Starting right off with Section 1, Causes and Key Symptoms. You know, the big risk factors here are long-term ulcerative colitis and a westernized diet, meaning one that's high in animal fat and noticeably low in fiber. But what actually happens inside the body once a tumor takes root? Let's walk through this incredibly logical cascade. As the tumor grows, it physically narrows the passageway inside the colon. Because that space is restricted, the stool has to squeeze through, which results in what we call pencil-thin feces. Eventually, it gets so tight the stool can't pass at all, leading to organic constipation. But it's not just the stool getting trapped. The normal gas produced by your intestinal bacteria gets blocked in there too. This trapped gas builds up, distending the abdomen, and, as the intestines forcefully expand and contract trying to clear out that blockage, it causes severe abdominal pain. Now, looking at that physical blockage we were just talking about, I want to test your understanding for a second. Does colon cancer cause a simple ileus or a strangulated ileus? Think about the physical mechanics of a growing tumor for a moment.
If you guessed a simple ileus, you hit the nail on the head. It's considered simple because the tumor just acts as a physical roadblock. It blocks the path of the stool and gas without twisting the intestine or cutting off the bowel's blood supply. If it cut off the blood supply, then we'd be dealing with a strangulated ileus.
Let's move to Section 2 and see how this builds. We've looked at the physical symptoms, so how do we clinically detect the disease?
Well, as tumors grow, they get fragile and they bleed. This causes microscopic amounts of blood to mix in with the stool. Because of this, one of our primary screening tools is a fecal occult blood test. But here is an absolutely critical detail. Tumors bleed intermittently, not constantly. So the test has to be conducted over exactly 2 days to ensure we don't accidentally miss a day where the tumor just simply wasn't bleeding.
Now, finding blood in the stool or seeing an elevated CEA tumor marker in blood work can definitely make us suspect cancer, but suspicion is not a diagnosis. A biopsy is the absolute requirement for a definitive diagnosis. We literally have to go in with a lower GI endoscopy, physically collect those suspicious cells, and look at them under a microscope to confirm exactly what we are dealing with.
So, once we have that diagnosis, the very next question is, has it spread? Let's explore Section 3, Routes of Cancer Metastasis.
Now, what's really interesting about this is the strict anatomical logic of how it travels. If cancer travels through the bloodstream, colon cancer almost always heads to the liver. Why? Because most of the GI tract drains directly into the portal vein, which leads right to the liver. But rectal cancer is different. The rectum drains into the vena cava, going back to the heart and straight into the lungs. If the cancer travels through the lymph system, it invades local lymph nodes, which blocks fluid absorption and causes localized swelling. And finally, peritoneal dissemination happens when the tumor literally breaks right through the outer wall of the intestine, scattering cancer seeds throughout the abdominal cavity, which eventually causes peritonitis. Where the cancer has spread dictates our treatment. For localized disease, surgery is the primary intervention. But as healthcare professionals, our real work kicks into high gear post-op. Let's look at Section 4, Surgery and Post-op Complications. The number one complication we absolutely must watch out for is suture failure. Remember, the GI tract is a hollow tube. When a surgeon cuts out a tumor and stitches the healthy ends of the intestine back together, that suture line is under constant threat. If that sutured wound fails and reopens, the internal contents, meaning digesting food or actual feces, will leak directly into the sterile abdominal cavity. It is an incredibly dangerous, life-threatening emergency. So, the crucial point is understanding why a suture might fail in the first place. It fails because the wound can't heal. Think of wound healing like a busy construction site. You need building materials, right? In the body, that's protein, specifically albumin. If a patient has liver issues, they don't have that material. You also need an energy source, which is oxygen. If a patient is anemic, they lack oxygen. You need immunity to fight off pathogens. And finally, you need a good delivery road to transport all this stuff to the wound site. That's good blood flow. If a patient has diabetes, their blood flow is compromised, effectively destroying that delivery road. Without these elements, a suture will fail.
And this brings us to a really terrifying clinical reality, the vicious cycle between suture failure and wound infection. If a suture fails, it allows bacteria to leak out, which instantly causes a massive wound infection. On the flip side, if pathogens invade the wound first and cause an infection, the resulting inflammation destroys the healing tissue, which causes the suture to fail. They feed into each other perfectly.
To catch these infections early, monitoring surgical drains is your first line of defense. But to spot a complication, you have to know what normal looks like. And this brilliantly illustrates the timeline of normal healing. Normally, post-op drain fluid progresses from bloody right after surgery to serous sanguineous, which is a pinkish, blood-tinged fluid, and finally to serous, which is a clear, yellowish, watery fluid. That is the healthy baseline.
But what happens when things go wrong? If you're looking at the drain and the fluid is brown and foul-smelling, that is an immediate red flag for suture failure in the digestive tract. You are literally seeing feces leaking into the drain. If the fluid becomes purulent, meaning it's creamy, highly viscous, basically like pus, along with localized redness and a fever, you are looking at a wound infection. Catching these changes early absolutely saves lives. Now, I want to add a brief word on rectal surgeries, like the Miles operation where the rectum and the anal sphincter are completely removed. This obviously requires the creation of a stoma, an artificial anus. But a massive, often hidden complication here is actually pelvic nerve damage. The pelvic nerves are what communicate bladder fullness to the brain. If surgery damages these nerves, the brain literally never gets the memo to urinate. The bladder just keeps filling up until it physically overflows. This leads to a specific type of urinary incontinence that requires really careful catheter management. Finally, let's wrap up with long-term management in Section 5, chemotherapy and side effects. The thing about chemotherapy is that it targets fast-dividing cells, but it can't tell the difference between a cancer cell and a healthy cell. This timeline is an invaluable roadmap for anticipating those collateral side effects. Because the GI mucosa is hit first, on days 2 and 3, you can expect severe nausea. From days 3 to 10, the lining of the mouth breaks down, causing stomatitis or mouth ulcers. Past week 1, we enter the critical phase of bone marrow suppression, and by week 2, we see the classic signs of hair loss and peripheral neuropathy. Let's zoom in on that week 1 danger zone, bone marrow suppression. Your bone marrow is the factory for your blood cells. When chemo suppresses it, we see a severe drop in 3 critical areas. A drop in red blood cells causes acute anemia, meaning a massive risk for fainting and falls. A drop in white blood cells essentially strips away the immune system, making even minor infections potentially fatal. And a drop in platelets means the blood can't clot, leading to a massive bleeding risk.
Another severe reaction you absolutely have to watch out for is tumor lysis syndrome. Believe it or not, this happens when chemotherapy is highly effective and destroys cancer cells rapidly. As millions of these cancer cells burst open all at once, they release an overwhelming wave of toxic intracellular contents directly into the bloodstream. These massive amounts of toxins rush right to the kidneys for filtering, which can easily and permanently destroy the renal system. To prevent this kind of shock, patients need massive amounts of IV fluids to flush the kidneys and keep those toxins diluted.
We have covered an incredible journey today, from the mechanical reality of how a tumor blocks the colon, through the anatomical logic of metastasis, all the way to the critical elements of wound healing and chemo management. So I'll leave you with this final, provocative thought. Knowing this exact logical cascade of causes, symptoms, and risks, how will you individualize your care plan for your next patient? Don't just look at the diagnosis, look at the whole map. Thank you so much for joining me on this explainer, and keep learning.